Good evening, everyone. It's an absolute pleasure to welcome you all to this very special session of the Endocrine Talk Show. Today marks a significant milestone as we celebrate the Silver Jubilee celebration of our monthly webinar series, Endocrine Talk Show. And I want to express my deepest gratitude to all of you, our speaker, our audience, and our organizing team. Your unwavering support help us making this program very successful. Your engagement that has driven the quality of discussion we have had today. And we recognize that endocrinology is a field as diverse as it's complex. And today's topics allow us to dwell into the variety of clinical scenarios that don't always fit neatly into textbook, but are crucial to our practice. It's about those day-to-day scenarios that require clinical judgment and expertise. So today we are going to discuss about that clinical scenario and various complex situations which will help us in making our practice more better. And to guide us today, we're having with us our co-director for the program, Dr. Professor Supankar Chaudhary sir. He's a director at Department of Diabetes and Endocrinology, Medical Super Specialty Hospital. And with this word, I hand over the session to Dr. Chaudhary sir and request him to introduce our panelists for today's program. Over to you, sir.
Thank you very much. A warm welcome on this special 25th edition of Endocrine Talk Show. While extending a warm welcome, I must say that I do this with a heavy heart today, on a somber note, with the recent turn of events, especially in Kolkata, but I'm sure that affects people all across the country and across the globe itself. A young physician cut short in her prime of life while on duty in a government medical college. So let's observe at least a minute's silence in memory of the departed life and also in solidarity with the bereaved family. We start now. Thank you. We start with the admission that this evening Dr. Arpandev Bhattacharya is unable to join us. We shall specially miss his experience, but I'm sure it will be more than met by the rest of the very exciting panelists that we have. So we have Dr. Hemant Patale, who is director of the Samrat Endocrine Institute in Aurangabad, and he is currently president of the Maharashtra Endocrine Society. And he has had a whole lot of other accolades to his name. And we also have Dr. Pramod Gandhi, who is director and consultant endocrinologist at the Gandhi Hospital in Nagpur. He's been a former secretary of the Maharashtra Endocrine Society, past president of Diabetes Association of India Nagpur branch, and so on and so forth. And he's been a faculty in so many national and international conferences in endocrinology. And he was the organizing secretary of the very successful ESICON 2019 held in Nagpur in 2019. And we have another very dynamic endocrinologist of our country, Dr. Sheila Sheikh, who is consultant endocrinologist at the Saifi Hospital and Reliance Hospital in Mumbai. He's been a principal investigator in international clinical trials and she has published many papers, review articles, and is also a speaker at national and international forum. So welcome all our faculties, welcome all our participants. As usual, please, for all our participants, for our audience across the country, please send in your questions. We shall try and answer as many of them as possible, but we may start off with a few. And as Dr. Mithilesh has correctly pointed out, endocrinology covers a vast panorama, and we shall try and pick up here and there a few questions, a few areas, some of which may be very common, some may be less common, but I'm sure all should have some learning point in them. So first, can I ask Dr. Pramod Gandhi? We all know the tremendous importance that statins have played in prevention of cardiovascular events. And most physicians have their own preference for a particular statin. And most commonly it's between atorvastatin and rosuvastatin. I think it's not only across endocrinologists, across cardiologists, physicians, all of them have their own options. But let's come to a real life situation of statin intolerance in a person who needs something for treatment. It's not just you can stop the statin because he or she has had a myocardial infarction about a year back. So how do we manage this as an endocrinologist, let us say, Dr. Pramod Gandhi?
Yeah, thank you, sir. As you rightly said, that statins are very commonly used in our day-to-day practice, and I think we
can I just stop you and ask? So, what is your favorite? Is it atorva or rosuva? And maybe I first declare my preference. My preference is atorvastatin. Nothing wrong about rosuvastatin though. So, Pramod, do you have any such choices?
No preference.
No. Okay. Okay. And the others, Shaila, Hemant.
Sir, I prefer.
Sorry.
Sir, I prefer rosuvastatin.
Rosuvastatin. Okay. Hemant.
I'd also rosuva because it's
okay. So I'm in the minority. I'm in the minority. Okay. Maybe. Yeah. Fine. Pramod. Yeah. Please go ahead.
There is nothing like minority or majority. Both statins are same. Only we need to give the corresponding doses. Otherwise, both the drugs are equally good. I think 20 milligram of atorvastatin is equivalent to 10 milligram of rosuvastatin. If we follow that rule, probably both the statins are good. As you rightly said, we see a lot of patients, practically all of our diabetic patients above 45 years of age, we put them on practically on statins. And as described in the literature, we do see almost 15 to 20% of these patients do have statin-induced statin intolerance, maybe myositis or.
So can I ask you, Pramod? So this is maybe you're quoting from literature, but is that your practice? Is that your practical experience? I somehow don't tend to see a whole lot of them having problems with statins. But yeah, what do you feel?
No, we probably see the all selected patients who are elderly and then associated with a lot of comorbidities. Probably that's the reason we might be seeing more number of patients with statin intolerance or statin-induced myositis. Now, there are various ways which we follow if patient has statin-induced myositis. There are few general instructions which we follow, and we tell it to our patient that they should maintain adequate hydration. We should supplement them with vitamin D or B12. If with that their symptoms subside, we try and counsel them, try to continue statin. If in spite of that, if patient has myositis, there are various ways. By either we try to reduce and give the minimum possible dose of statin. Maybe lowest possible dose which has been recommended is 5 milligram of atorvastatin. If patient is not tolerating the even 10 milligram of atorvastatin, then also we can shift him to 5 milligram of atorvastatin. If patient is still not tolerating, maybe we can give alternate day therapy or twice a week therapy. These are all recommendations which are recommended for the patients who are not tolerating statins. And if still patient has symptoms, maybe we can shift them to other lipid lowering agents like bempedoic acid or other agents. Again, statin-induced myositis is more common when we use statins along with fenofibrate, which is very commonly used by most of the people. So if you are using combination, that then chances of myositis are higher. Therefore, try to give statins alone, not along with fibrates if patient has myositis.
Right. So can I quickly ask Dr. Hemant? So what is a CPK cutoff that you would take where you would withhold statins?
I think there are no specific cutoffs as such, but anything which is defined normal for that population and that race, maybe uh, uh, maybe 40, 40, 45, more than that. But anything which is causing myositis, such as other factors like Pramod was talking, that maybe an uncontrolled hypothyroidism, which is one of the common comorbidities or common condition, which is associated with a diabetes which is not controlled, might be responsible for rising CPK and maybe muscle pain or untreated, unnoticed hypoglycemia as well.
Right. So, if an individual, Pramod, once again, so if let's say the CPK is somewhat elevated, maybe many standard recommendations suggest only if it goes beyond 10 times the upper limit of normal, then that's an absolute indication that you stop the statin. If it's between, let's say, 3 and 10 times, maybe you observe and right.
Yeah, try to reduce the dose.
Right.
Anything more than 2 times of the upper limit of normal, you need to be very careful and monitor them more frequently in terms of their CPK.
Right. So in those instances, would ezetimibe be a good choice, alternative?
Ezetimibe is a good lowering agent, but then CV benefits of ezetimibe alone has not been described. When ezetimibe is added along with statins, then CV benefits were more. So
right. Okay. Fair enough. So statins are very important. I'm sure all of our physician colleagues use statins once in a while, so we have got some idea. The other issue that comes to my mind is in terms of let's say lipophilicity versus hydrophilicity. I mean, rosuvastatin is supposed to be water soluble. Atorvastatin is stated to be lipid soluble. So theoretically, at least to me, it means that many side effects may be more with atorvastatin because it can enter different cells more easily. Is that true, Sheila? Do you think so?
So basically, when you say lipophilic, it means it dissolves in other hydrophilic substances and in other lipophilic substances. So I think the only area where I personally use atorvastatin, sir, is in patients with any kind of renal issue. Then I shift the patient from a rosuvastatin to an atorvastatin because the area of concern with rosuvastatin is mainly renal. So in those patients, I shift, sir. Otherwise, else I prefer using rosuvastatin.
Right. So that's a very important issue raised, that some concern with renal, but there also I feel that most of the evidence is that maybe even with rosuvastatin, there is transient and relatively mild proteinuria that has been described rather than actual worsening of renal function. But yeah, so I think we had a lot of discussion on statins. Can we still be on a common area of diabetes and obesity and have Dr. Sheila Sheikh give us some practical advice as to how to continue on, or what do we do if a person who is on a GLP-1 receptor analog, and these are now available, both injectable as well as oral in our country, are being used more widely these days and have a lot of positive effects. So, and GI side effects are quite common as well. So how do you manage these patients? Do you stop the GLP-1 receptor analog?
Sir, I don't stop the GLP-1 receptor analogs. First of all, sir, I think it's very important that when you give a prescription to a patient of GLP-1 analogs, you educate the patient regarding these possible side effects. I think if you have educated the patient and the patient is aware regarding these side effects, the patient is able to cope with them much better because they are preempting them. They know that, okay, possibly I could be having these side effects initially. And because we are expecting that, I mean, almost 15 to 20% of our patients would potentially have maybe mild to moderate side effects. That's the reason we are starting from a lower dose and gradually we're going to up titrate the dose. Often, sir, these effects are seen more when we're up titrating the dose, when you're increasing the dose subsequently. And some of the general recommendations which we've seen work quite well with our patients are even when we're writing the initial first prescription, so that it gradually becomes a habit with patients, are some of the recommendations regarding eating habits, sir. For example, we tell our patients to eat much more slowly, eat smaller portions, not lie down immediately after meals, and eat only, and stop eating when they are feeling full. Avoid drinking too much of water along with their meals, maybe 1 hour prior to the meal and 1 hour post the meal. We also ask them to be a little more careful with their fat content, if possibly reduce the fat in their diet. We tell them to avoid spicy food. And we also tell them, if possible, sir, we nowadays also tell them, if possible, to walk for 10 minutes post their meals, because we found that also really helps the patient, sir. So in spite of that, if we have found that the patient still is very, very uncomfortable, is just not comfortable, we also maybe ask, I mean, practically, sir, what we also ask them is to maybe have some ginger-based food about half an hour after the meal, because that makes them feel a little better. In spite of that, if they're having nausea, sir, we give them prokinetics, we can give them domperidone, sir, to try to help them with that. So often we have seen that when we're up titrating the dose, for example, if you're moving from 3 milligram to 7 milligram of semaglutide, what we have seen that these patients can have worsening of symptoms. If the worsening of symptoms is very, very significant, we often down titrate the dose again till the patient is much more comfortable. And only once the patient is again comfortable, then we will again slowly escalate the dose and move to a higher dose and try to see whether the patient tolerates. One thing which helps, sir, is if we tell them this is temporary, this is transient, most of the symptoms are going to resolve with time. And if you can sort of stick it out, this is really going to give you good benefit. So a good conversation, sir, I feel does the job, to be very honest with you.
Absolutely, I fully agree. And what about the ubiquitously used pantoprazole domperidone combination or pantoprazole only? Everyone takes it, and then the patient would have already have tried it. So does it help?
So I think domperidone, yes, domperidone would help because it's a prokinetic. I'm not very, very convinced of the pantoprazole. And either way, when we are giving semaglutide, sir, we need to give it empty stomach. At least that's also very important that we give instructions the right way. We're supposed to be taken empty stomach fasting. You cannot eat or drink anything for half an hour. And maximum you're allowed 120 ml of water. Even extra water interferes with the absorption of semaglutide according to the PKPD studies, sir. So it's very important, because if the patient doesn't take the drug the right way, sometimes the patient honestly, sir, has no symptoms at all. I recheck whether you've taken it the right way, because you suddenly realize that though you've given instructions, the patient is taking it in some completely different manner whatsoever. So sometimes that can be a hint that maybe the patient is not taking it exactly the right way. So I prefer just using a prokinetic. So I don't use, we may use pantoprazole if there's severe gastritis or things like that. So, but half an hour later.
Right. Excellent. And I think we also have to accept that in some instances, we have to go down to the lower dose and be happy with whatever the dose that suits this particular individual. Right.
So can I add something?
Sorry, yes, please.
So the one thing which I've realized is the low dose set affects satiety very well. So sometimes I may use a lower dose just for the satiety effect rather than anything else, just practically.
Right. So your higher dose is for what? For
so
glycemic control?
Yes, hyperglycemic control, definitely a 7 or a 14 milligram. But my practical observation is that with 3 milligram also does have some influence on satiety, just an observation.
Yeah. So I think that's also an important message, that even the smallest dose does have an effect. So even the patient doesn't need to be disappointed that this will not have any effect on my overall clinical condition. So now we come to Dr. Hemant Patale. So we do know that hyperthyroidism is not as common as hypothyroidism. but it is there, and medical management is one way of treating hyperthyroidism. And the thionamides, methimazole, carbimazole, are effective drugs, but they carry with them some adverse effects, which are, of course, rare adverse effects. They're not common side effects, as we talked about the GI side effects with the GLP-1 receptor analogs. One such is agranulocytosis. So let's say you have your patient who is on methimazole and has developed agranulocytosis. So what would you do?
Thank you for this question. I think, as you said, this is a rare side effect. And the term is granulocytosis essentially means granulocyte count less than 500 per microliter. It is a dose dependent, and it may develop in most of the times maybe 2/3 cases in the initial 2 to 3 months of the starting treatment. And usually these patients will present with sore throat and fever, and we need to educate patient. We need to inform the patient once we put on this patient on the anti-thyroid drug, maybe initially in higher doses to begin with. And if such develops, they should immediately consult nearest doctor and get the count done, and that may help in picking up early. If you picked up early, and then it's just stopping the drug, which is the reversal, and then we may prefer to the other drugs like with beta blockers and maybe definitely mode of therapy like radiation therapy. But if this condition is serious, and where febrile illness is patient brought to the doctor very late, and in which case a broad spectrum antibiotic, maybe a third generation cephalosporin, fourth generation cephalosporin, covering both gram positive, gram negative, take the culture and then start antibiotics. And this patient might need admission and isolation as well. If count goes less than 100 cell per microliter, maybe a granulocyte stability factor might help you in a reduction in a hospital stay patient. As I said, it is a dose dependent. It is reversal once we stop the therapy as such. And in which case we need to go with beta blockers, then SSRI, saturated solution of potassium iodide, and after control, we may subject for the subtotal therapy. And I'll take another minute or so. Do all the patients develop such reaction? No. There is some HLA link has been described, like HLA-B28, HLA-B20, 27, 32, and maybe an HLA-DR8 allele has been described to be supposed to be develop such kind of side effect. A few words on leukopenia also. The disease per se, Graves' disease, can cause leukopenia even before starting the anti-thyroid drugs, and this is possibly because of autoimmune phenomena has been described for this patient.
Right. So what about after the patient recovers? And in most cases, fortunately, the patient does recover. What about switching from methimazole to propyl thiouracil, another thionamide?
I think all thyroids have the same side effects. We should not do that.
Right. So we should go for a definitive treatment.
Yes.
Right? Okay. Yeah. Right. So can I come back to Dr. Shaila Sheikh? So hypertension is very common, even more common in those who have got diabetes. And common treatment for hypertension is with calcium channel blockers, apart from ACE inhibitors, ARBs. But let's say we have a patient, sorry, before I go there, sorry. We have quite a few questions in the chat box. Sorry, I'll come back to you, Shaila, with this. But this is for you, especially, Dr. Panchal. And maybe he is on my side trying to defend the host or the moderator, that diabetes patients frequently have renal impairment. Why we should consider rosuvastatin if atorvastatin has equal efficacy with better safety? Do you need to? And I didn't prompt this question to Dr. Panchal.
So, there are definitely studies which show that rosuvastatin, the safety profile of rosuvastatin is, I mean, this is going to be an unending.
Right. Yeah, so overall, rosuvastatin is actually quite a safe drug, and even in renal impairment, I don't think there is an absolute contraindication to the use of rosuvastatin, right? And maybe can we have Dr. Pramod,
Yes,
Dr.
please.
Bhandari? Though semaglutide was something that Sheila mentioned, but Dr. Bhandari wants to know whether oral semaglutide has similar side effects as injectable. And that's very relevant. The GI side effects, we always, if someone has oral iron and GI side effects, I suggest that you go for intravenous iron. So now, if someone has side effects, GI side effects on oral semaglutide, can we go on to injectable, not semaglutide yet in our country, but dulaglutide or whatever liraglutide? What
I think
about it?
I think GI side effects are almost equal in both, whether you are taking oral or injectable. The GI side effects are almost similar with both GLP-1 analogs.
Right.
It's more of dose dependent rather than the molecule, we can say. At lower dose,
That's
GI side effects are less. At higher dose, GI side effects are more.
right. An oral versus injectable is not likely to make a difference. And for Dr. Hemant Patale, Dr. P.K. Gupta, how long we should continue GLP-1 receptor analog if significant weight control is achieved and diabetes is under good control, A1C less than 7, and patient is having on and off GI side effects. Let's say patient doesn't have side effects, so how long should we continue?
Should be patient can afford go for lifelong. Unless
Sorry?
if patient can afford, it can go for lifelong. Because besides glycemia, there is a significant weight reduction and there is significant reversal of atherosclerosis at the maybe a vascular level. So vasculopathy is being taken care of, and this is one of the major which has been cardioprotective, renal protective of GLP-1 receptor advantage.
Right. And I think the same, it's something similar to many issue that many of my patients, I'm sure they come to you also saying, doctor, my TSH has now come down to normal, so can I now stop the thyroxine? So it's somewhat similar. So if you stop the drug, then again the A1C will go up if this was effective in lowering the A1C. So we do have to continue. So we come back to Sheila. So hypertension on amlodipine and chlorthalidone has got potassium of 2.8 or about 3, just lowish potassium. So how do you manage?
So
or how do you approach rather?
So hypertension, if the patient is having a hypokalemia at the same time, there are 2 or 3 things. First of all, so this patient has chlorthalidone. Chlorthalidone itself can cause hypokalemia. So the first thing I would do was it would stop the chlorthalidone and reevaluate the patient and see what the patient's potassium is. If the patient's subsequent potassium is also low, then in the patient, young patient, hypertension. So depending again on the hypertension, I mean, is it uncontrolled hypertension or is he well? I mean, clinical factors which I would consider in this patient. If he's uncontrolled on 2 or 3 drugs with hypokalemia, then my first differential would be whether I'll be dealing with a situation of hyperaldosteronism. So if I've ruled out, some of the herbal medications also interfere and they do cause hypokalemia. So I get a little worried. I will definitely ask him whether there's some other medication which he's taking. And if this patient is having hypokalemia along with the situation, and my first differential would be, I would first want to correct this patient's potassium and then evaluate this patient for a aldosterone PRA ratio. It's very important that the patient has an adequate sodium diet at least for 3 days. You correct the potassium levels because hypokalemia itself can interfere with the aldosterone and it can reduce the aldosterone. Once we have done this, then we would in an upright position ask this patient to undergo a test for aldosterone PRA. So this patient, if this patient was on beta blockers, again, I would potentially stop the beta blockers and start because drugs can interfere with the aldosterone levels too. And depending on the result which I get, for example, I mean, either some studies show that you take an isolated aldosterone level also, which is more than 15, 20 different authors quote different numbers, either 15 or 20. Or then we take a PRA, I mean, an aldosterone PRA ratio. And if that is more than 30, again, you would consider that to be 25 to 30, you would consider that to be significant and then investigate the patient accordingly, sir.
Right. And these days, primary aldosteronism is supposed to be pretty common in garden variety of hypertension itself, and that hypokalemia apparently doesn't is present maybe only in a small percentage of cases of primary aldosteronism. So absence of hypokalemia does not exclude. But do we, I mean, can I ask all of you? I mean, you all see, I mean, we all see so many patients with hypertension in our practice with diabetes, especially. Do we screen them for hyperaldosteronism? I mean, what are the clues? Where would we specifically look? I mean, you already identified some. If it's a young onset hypertension, is what you said. One. The other is, of course, if there's hypokalemia. And hypokalemia, mind you, it's suggested that even diuretic-induced hypokalemia should raise our antenna that this could be primary aldosteronism. And then would there be other indicators?
Resistant hypertension. Any patient who is more than on 3 drugs of 3 antihypertensive drugs, they should be evaluated for primary hyperaldosteronism.
Right. Yeah. And also even family history of young onset hypertension and so on and so forth. Right. And I think our audience is still fixated with GLP-1 receptor analog. So whoever wants to take it, Dr. Bhandari, any idea why injectable semaglutide is not available in India? Oral sema is not proven for CV benefits and made available in India earlier than injectable. Right. Any comments? Who would like to take it?
So it's not.
Yeah.
So it's not available. It's not available because it's like a demand and supply situation. They are unable to produce that much quantity to be able to sort of make it available to us. That's what I understand.
Yeah, similar, I think.
Commercial value, so commercial reasons, to be honest.
Not approved also in India.
Yes, yeah. No, actually it's approved. Pramod, DCGI has approved injectable and for at the weight loss dose. Anti-diabetic. Yes. Yeah, the higher dose that is approved in our country, but the company is not able to get it or doesn't think it's yet commercially viable, whatever. Right. So now we have, can we have Dr. Patale? So a young lady, 10 weeks gestation, she's been found to have a TSH of 35. And her gynecologist obstetrician has said, you should go for a medical termination. And she's now come to you. What do you do?
So it's a very common condition which we face across. Patient is already known case of hypothyroidism. We need to educate the patient the importance of
only now she's been diagnosed to have a TSH, not a known case of hypothyroidism.
Perfect. Then we need to educate the patient regarding the disease per se, the importance of treatment, its effect on the mother as well as baby. Untreated patients with TSH may have enormous weight gain during pregnancy, maybe hypertension during pregnancy, maybe preeclampsia and fetal losses, fetal wastages, and then maybe a neuronal development effect on baby in terms of maybe less intelligence and not properly developed baby. And that's how the effect we need to educate the patients. And we need to explain the patient regarding that patient medicine which is required. Maybe begin with a 100 microgram empty stomach and should not take anything for 45 minutes, and then she can have maybe tea or coffee or milk later on. And particular things she should avoid other medications immediately coming 3 to 4 hours after taking the levothyroxine. And I need to discuss with my colleagues, the obstetric colleague, regarding the termination of pregnancy is not indicated. None of the guidelines explains or recommends the termination of pregnancy. We need to treat this patient, and once we start this treatment, every 4 to 6 weekly we check on our the thyroid function test and escalate the dose which is required. Patient should avoid the commonest protein powder which is prescribed by our obstetrician colleague, which does contain soybean and sometimes interferes with the absorption in the assay. And such patients, if required, then maybe a protein can be taken in the evening, not in the morning hours. So we need to educate the patient and discuss and educate our colleague as well.
Here, I mean, do you think that untreated primary hypothyroidism in the first trimester is associated with higher risk of congenital malformations? Because if that has happened by 10 weeks, that would have happened.
Yeah.
Even rendering her euthyroid in the next 4 to 6 weeks will not revert that. So can we assure them confidently, no, hypothyroidism does not cause congenital malformations?
Usually instead of congenital malformation, they are not so common, but definitely the neuronal developments get affected to the
so
baby.
that we can possibly take. Okay.
And if at all if some develops as a pulmonary heart disease has been described with such babies, and we need to explain to the patients, and the relatives should take a call whether they want to continue. We should put forward all the knowledge and data, but none of the guidelines recommends the termination.
Yeah. Right. So this is an area I think we as endocrinologists, as physicians, could help the patients and not go for unnecessary, uncalled for medical termination. So we have a question, Dr. Charu. Should a patient with normal TSH in the first trimester be screened again during subsequent trimesters? Yes, Dr. Hemant.
Yes.
You are the thyroid person now.
Okay. See, if patient has goiter and he has a strong family history of hypothyroidism or maybe an autoimmune thyroidism for that matter, such patient should be need to repeat the TSH value. The normal subclinical hypothyroidism may be TSH in the first trimester or second trimester. We need to treat them and see that your TSH targeted value during pregnancy. Maybe first trimester less than 2.5 and second and third trimester less than 3. We need to keep that.
Right. Maybe today we are a little bit more relaxed about the TSH cutoffs, maybe even up to 4 or 4.5, what is possibly accepted. Right. So we come back to Dr. Sheila. Do you use pioglitazone anymore, or?
Sir, I do use pioglitazone.
You do use? Okay. So I still do use, and this patient of mine who is 60 years is a lady, but she has come to me new. She's been treated elsewhere. Her A1C is reasonable, 6.7%. She's had the disease for 10 years at least, or maybe longer. And she's on a sulfonylurea, metformin, pioglitazone regime, not one of the modern ones, not the GLP-1 receptor analogs, but she's otherwise doing well. Now, she had a DEXA BMD done, and it suggests she has got osteoporosis. So is there any change that you want to make to your treatment, or how do you discuss this with your patient? Patient is quite happy. Currently, reports are reasonably good.
Sir, a 60-year-old lady who's having osteoporosis and who's having an HbA1c of 6.7%, there would be two drugs which I would be interested in addressing in this lady. So there are two things in the history you told me. You told me there's a long history of diabetes. You said 10 years of diabetes. Diabetes itself also affects the bone, sir. Diabetes itself is associated with an increased risk of osteoporosis. And also this lady's postmenopausal, so that also has increased her risk of osteoporosis. Now at this point of time, so you said this lady is happy, fine. So we need to prevent any further risk of fractures for her. So when we're talking about further risk of fractures, sir, we would look at it this way, that we need to prevent any kind of fall, any kind of injury, because we know that can be catastrophic for this lady. Now, if I look at an HbA1c of 6.7 and I look at the fact that she's on an SU, though she's very, very happy, and her pioglitazone, There are two things I would ask her. So one, I would also be worried about any kind of hypoglycemia occurring with an HbA1c of 6.7, because any hypoglycemia can increase the potential risk of a fall and a subsequent fracture in this lady. And I would also be interested in maybe reducing or stopping the pioglitazone, so depending on the dose gradually, because
But the
pioglitazone.
hypoglycemia will come from the sulfonylurea component. So you stop the sulfonylurea.
Sulfonylurea, I will stop, sir, and pioglitazone. Sulfonylurea will cause hypoglycemia, pioglitazone will affect the bone, sir.
The
And diabetes
A1C,
itself is also affecting the bone.
I guarantee the A1C will go to 8.5.
So it will go to 8.5. You have newer molecules. So you said she's not on a DPP-4 inhibitor, she's not on a GLP-1 receptor agonist, and neither is she on an SGLT2 inhibitor. So I have 3 molecules to maintain that HbA1c, sir, where we want it to be. So I would still want to use those molecules in her other than use this. What I would possibly do, sir, is not stop the sulfonylurea completely, but reduce the sulfonylurea to a dose where I don't allow it to go up to 8 plus, sir. I would most probably readjust the dose a little and keep it around 7, and then use the other agents which would not cause so much of hypoglycemia, sir. Because in her, I would really be worried about any kind of potential catastrophe, sir, as a result of osteoporosis. So, and I would also want to treat the osteoporosis alongside. I definitely would want to, along with whatever we do to prevent medications causing the problem, because we have 2-3 risk factors over here. We have the basic diabetes as a risk factor. We have her age as the risk factor. We have her being postmenopausal as the risk factor. And on top of that, we have drugs as a risk factor and the long duration of diabetes. So we would definitely want to treat the bones along with everything else, sir.
Right. I think that's very well put. And we also do remember that in diabetes type 2 especially, the risk of fracture is not the story is not entirely revealed by the bone density. Even with a reasonably good bone density, you can have bad bone quality and risk of fractures.
Yes.
Right. So and then you raised the very important issue of not just the bone part, but the other component of fractures, that is falls and all, those also need to be addressed as far as possible. So while we did say that Dr. Hemant Vatale is the thyroid person, but I think Dr. Pramod Gandhi is no less an expert. So Dr. Gandhi is for you. Dr. Mansoori, is it necessary? That's the question from Dr. Mansoori. Is it necessary to treat subclinical hypothyroidism in pregnancy? If yes, how?
Yes, obviously, we need to treat subclinical hypothyroidism during pregnancy aggressively. There is no doubt about it. The recommendations are any patient whose TSH is between 4 to 10, they should be treated aggressively and they should be started on thyroxine straight away. Any patient whose TSH is between 2.5 to 4, along with anti-TPO positivity, the benefit of doubt should be given to these patients, and you may treat these patients with low dose thyroxine, 25 microgram of thyroxine. These patients may be treated if anti-TPO are positive. Otherwise, all patients with TSH more than 4 should be treated aggressively.
Right. And we have, okay. So we stay with you, Dr. Pramod. So yes. we because we're still on thyroid issues, and subclinical hypothyroidism is something which is very common. We do know, and as you mentioned, subclinical hypothyroidism, one of the indications for treating is pregnancy or even planning for pregnancy. We would treat them.
Yes.
A related issue with subclinical hypothyroidism is that these individuals are known to have a higher cardiovascular event risk, and that may be partly related to dyslipidemia.
Yes.
So you have a patient who has subclinical hypothyroidism with a TSH of 6.5, just a little bit TSH above the upper limit of normal. Free T4 is normal. The LDL is significantly elevated at 165. So how do you approach this individual? Do you treat with statins or do you treat with thyroxine? What do you do?
ideally we need to categorize this patient into various risk groups. And since his LDL is 165, so he obviously falls in high risk category. So any patient who is in high risk category, we need to treat this patient by correcting their secondary factors like subclinical hypothyroidism. Along with that, just by giving thyroxine, we can't bring down his LDL cholesterol from 165 to target LDL, which may differ from person to person based on the various risk category. So our LDL target differs. We don't know the risk category in which this fellow falls. So even if we keep our target of LDL of less than 100 in this patient, then also just by starting thyroxine, it will be extremely difficult to control the LDL level or bring down the LDL level to less than 100. So we need to start thyroxine. Along with that, after correction of hypothyroidism, we need to start statin also in this patient, so that we can definitely, as we discussed, we can prevent the myositis, which is very common in hypothyroid patient, by statins. So we need to start statins after correction of hypothyroidism in this patient.
Okay. We come to Dr. Hemant Patale. So this is now still, I mean, coming back to the issue of bone health. And really, bone health is also an area that endocrinologists are deeply involved in. It's not just the orthopedics who manage. I mean, they of course have to manage after a fracture, but before a fracture and for prevention of fractures, I think we have a big role to play, and also physicians have a role to play. So a 65-year-old lady has got osteoporosis, known osteoporosis, has been on treatment, intravenous zoledronic acid once a year. That's what she has agreed to have. She has had it for 5 years now, but her bone density, the DEXA bone density test, still shows that she is in the osteoporotic zone. So what should we do? She has had 5 years of treatment and still she's osteoporotic.
Okay. As I said, it is a very osteoporosis. I will look at as such the bone mineral density gram per meter square. Begin with the therapy, before the therapy, and presently. And with this, if there is no improvement or the worsening, I need to look at some secondary factors which might be playing, like maybe patients having associated anemia. We like to rule out something like multiple myeloma, or if patient associated hyperthyroidism, we should treat that also. And so we need to rule out secondary causes for that. And maybe a hyperparathyroidism also sometimes can cause asymptomatic hypercalcemia, hyperparathyroidism. So we need to look at the two vitamin D levels, calcium, phosphorus, the PTH levels, and that will guide whether this secondary part of it, whether it's involved. If that is being ruled out, as such, even in a patient who is already, even if responding patient, we need to be presently recommended for the sequential therapy. And this patient, as I said, is a worsening with the lumbar spine. I think, as I said, it's a we need to the second drug of choice will be once the secondary cause is ruled out, we should go for the teriparatide or abaloparatide treatment, maybe. And as a sequential therapy, in 3 years, we need to recommend to change the anabolic like abaloparatide or teriparatide, maybe 20 microgram daily for 2 to 3 years of therapy. There are certain bone markers which is being are there like osteocalcin and other markers which can help whether this patient is responding in terms of the bone mineral improvement. Is that though there is a not showing on as far as the T score is concerned in these patients.
Right. Yeah. So, and what about continuing on IV zoledronic acid?
No, we should discontinue that. Yeah, we should discontinue. As I said, it's sequential therapy. We may 2 to 3 years later on. Also, we may come back to be again bisphosphonate once the patient is settled, and then this is a way that we can avoid the vascular necrosis or the necrosis at the jaw, which has been described as a side effect. So, sequential therapy will reduce the other side effects.
Right. Avascular necrosis or atypical femoral fracture, both are, of
Yes.
course, rare events, but they do occur once in a while. Right. So, we have a question from Dr. Balkrishna. Maybe Dr. Pramod, if you would take that. Low level of magnesium associated with low potassium. Your comments. I do not know
In a
exactly. Yeah.
in a hypertensive patient or in a non-hypertensive patient,
Uh,
that's a separate.
it's
I think in a
no, that's not
hypertensive, we have,
specified.
yeah.
We discussed in relation to hypertension,
Mm.
but our doctor has not specified that.
I think low potassium hypokalemia, we need to find out the cause of the hypokalemia in this patient. Hypokalemia and hypomagnesemia hand in hand go in only in one condition, probably renal tubular acidosis, where we need to treat the
Right.
RTA with salt solution and other thing. So I think we need to find out common pathology or whether it is a separate pathology. That's the first important thing. And then probably we can move ahead.
Right. And low level magnesium possibly, excuse me, is more often or more correlated with low calcium level.
Calcium,
But I
yeah.
don't know. Yeah.
I-
Right. And we have Dr. Ashok Desai for Sheila, because you are the GLP-1 person. So if GLP-1 analog given in non-diabetic patient only for weight loss, then how long the dose should be given?
So ideally, it is supposed to be again be given lifelong, because the data shows that when you stop GLP-1 receptor analogs, there is again there's a rebound weight gain which occurs slowly. So basically, even if to maintain that weight loss, you would be continuing the GLP-1 receptor analogs.
Right. Yeah. Yes. Someone else had a comment?
Yeah, and the dose for anti-obesity dose of GLP-1 analog is different than anti-diabetic agent. That's very important. That has to be kept in mind.
Sure. Sure. And for all of you, and also for those who have registered, more than 1,700 delegates have registered. I don't know how many have tuned in this evening. So a very important question has been raised by Dr. Kiran Shah, not Kiran Shaw, Kiran Shah. Role of statin in diabetes with heart failure. Is it beneficial? So we're talking of heart failure and statins. So who would like to take it? Anyone? Yes, Pramod?
Yeah, heart failure in a patient with established coronary artery disease, there is definite role of statins. The role of statins in patients with dilated cardiomyopathy with heart failure is big question, which is not established. So we have to evaluate what is the reason for heart failure, and then probably we can decide whether it will be beneficial or not. With a coronary artery disease, definitely established evidence.
I suppose all of us agree on this, that as an anti-heart failure measure, possibly directly, statins do not have a big role compared to some other agents that we today have at our disposal. And then finally, can we, because we have already come to the end of our time limit, 1 hour, but maybe we'll just overshoot and ask about another common condition, polycystic ovarian disease. Dr. Hemant Patale, please. How do I manage hirsutism in a 22-year-old young lady with hirsutism and who is also obese?
This very common condition, the PCOD, obese PCOD, we see come across in our clinical practice. Hirsutism and acne, the irregular menses, and secondary amenorrhea is one of the common presentation. We need to evaluate in terms of the FNG score, maybe an hirsutism, how severe it is and how rapidly it is occurred actually. And we need to go check the androgen levels, and that actually helps us in if androgen levels more than 2 nanogram per ml, maybe, and we are dealing with something else, and then maybe tumorous or some adrenal origin, maybe the cause for this PCOD. So there is a secondary cause for PCOD and hyperandrogenism. We need to rule out that. But the commonest being is the obesity, insulin resistance, and being is responsible for the hyperandrogenism and hirsutism. We need to address first. We need to ask first to reduce the weight, 10% weight loss, and that can be achieved with some lifestyle modification and metformin or weight loss drugs. In addition to that, we need to go for the anti-androgenic OC pills. OC pills helps in the
Dr. Hemant, so the mother asks, if my daughter is able to lose weight, will she be able to get rid of her hair over the upper lip and the chin?
Okay, fine. The PCOD is a lifelong disease, and if we don't make a friendship with the disease, we don't take care of the disease players. The hairs, once it is appeared, it cannot go away. But definitely the quality of hairs, like the realization of hairs can be reversed. Maybe in the thick one of the hairs will be thinned out, and the rate of the growth of the hairs will be reduced. So there are some other measures which is required. Like once the androgens levels are settled, so weight loss is occurred and the cycles being regularized, we need to ask the patient for the growth of laser therapy or some other ways to go to the removal of the hair and maintaining the cosmetic part of it.
And you mentioned about anti-androgen. So which anti-androgen do you use?
Usually cyclotrin acetate containing OC pills, which are drospirenol. Keeping in mind that these may cause sometimes some side effects in terms of maybe an cavernous sinus thrombosis, which is one of the not common, but we always keep in mind with.
Yeah. So what about anyone else does use spironolactone as an anti-androgen?
We do use
Yes,
spironolactone and cyclotron acetate both, but though not in combination. Spironolactone can be used alone, but sometimes it may cause irregularity in cycles. In that case, we might have to add OC pills. And if you are using it has been shown that whether you use cyclotron acetate along with ethylene estradiol or spironolactone, efficacy is almost similar. There is no benefit of adding both these drugs together. So you use any of these agents alone.
Right. So we come to the last question, which is addressed by Dr. Verma. So, and I have to take help of one of you, Dr. Sheila, maybe, because what Dr. Verma mentioned is recent prevent score, ACC-AHA, can predict heart failure risk. Now, I must admit, I do not know about the prevent score. So Sheila must be knowing. So in such cases, should we use pioglitazone and DPP-4 inhibitors or avoid it if no active symptoms of or heart failure, or maybe of heart failure? So even if a person doesn't have symptoms of heart failure, maybe the prevent score can give you a risk for heart failure. If the risk is high, should we avoid pioglitazone and DPP-4 inhibitor? Is how I interpret the question, Sheila.
Sir, what I know about the prevent score is basically it is used for predicting risk of cardiovascular disease events. That is an AHA score.
Not heart failure.
So this app should be used for primary prevention. They have said those without ASCVD or heart failure. This should be used for primary prevention, sir. That's what I remember.
And the advantage of prevent is that it can be used at a younger age group, maybe 30 years onwards. And they do consider the BMI as one of the risk factors, which AHA is not considering.
Thanks.
The lipid profile is considered, the blood pressure is considered, BMI, EGFR, if I'm not mistaken, diabetes, smoking, antihypertensive medication, and lipid lowering medication is considered. I think USCR and HbA1c is also there somewhere, and then it is calculated, sir. And this is basically a primary prevention, if, as Dr. Patel is rightly saying, for people between the ages of 30 to 79 years. And this was basically it's a risk equation, sir. And a low risk is less than 5%, sir, and a borderline risk is 5 to 7.5, with a high risk
Right.
more than 20. I'm sure of that.
Right. Okay. So, but once again, it's not specific for heart failure. It's for cardiovascular events.
So it's for both. It's for ASCVD.
Yeah.
They've said those at present, without ASCVD or heart failure, you can use it. And it is useful for prediction of both. There's a risk. It's for 3 columns of this, sir. ASCVD, CVD, and heart failure. So I think for all 3, you can calculate separately, sir, according to these parameters.
So if the score is high, do we preclude pioglitazone DPP4 inhibitor?
Sir, I don't think I would preclude, because pioglitazone otherwise is also an insulin sensitizer. I mean, and if you look at the PROACT study and so the studies which pioglitazone, it does prevent stroke. So I would say that in our patient population, sir, a low dose of pioglitazone, especially with the insulin resistance that we are dealing with, is actually a good drug to use in low doses, sir. So I don't think I would preclude the dose. Maybe with a patient high risk, I would give SGLT2 inhibitors a much upper place, but we are either way doing that in routine clinical practice nowadays, sir. We are considering the use of SGLT2 inhibitors much higher up over there, sir. So I think...
yeah, and whatever our colleague has in mind, I think what he has in mind is heart failure risk. So let's say if someone has a high risk for heart failure, whatever way we can predict that, what is your take on the use of DPP4 inhibitors? Do you think it's harmful?
So I don't think it's harmful. It's shown to be absolutely cardiosafe. In heart failure, DPP4 inhibitors are not harmful. They are not protective, but they're definitely not harmful.
Yes, only the SAXA study.
The SAXA story we all know. The SAXA story we all know, but we don't use SAXA any longer. So other than SAXA, so it's not been implicated as far as...
even later studies with SAXA also proved to be not.
Agree. I totally agree, Dr. Patale. Absolutely agree.
But of course, now we have got better agents which can actually counteract heart failure. So maybe in such a situation, we'll be using those agents rather than DPP4. So I think we had a wonderful discussion. Clearly, we cannot cover all of endocrinology in 1 hour, but we did try and cover some of the common areas, and it's always such a pleasure to have an excellent faculty, panelists, and who can always help you out when maybe the moderator doesn't know what the prevent score is. You always have help close by. So I would like to thank once again all of you, all our audience from across the country who have shown interest over the years, over the last 24, and this is the 25th episode of this Endocrine Talk Show. I hope it does help you in improving your clinical practice. And I'm really very thankful to all our panelists this evening, Dr. Pramod Gandhi, Dr. Hemant Patale, and Dr. Sheda Sheikh. And of course, to the INTAS team for making this happen over the months and years together. So it's back to Dr. Mithilesh Nayak.
Yeah, thank you, sir. It is my honor to deliver the vote of thanks for this landmark session. First and foremost, I would like to extend our deepest gratitude to our distinguished speaker tonight. Your insight and expertise have not only enlightened us, but also provided practical takeaways that we can all apply in our practices. Your contribution have truly made this Silver Jubilee Session one to remember. We extend our deepest gratitude to our course director, Dr. Chaudhary, whose insightful guidance and thoughtful curation of the topics truly captivated our interest and enriched our learning experience throughout the past 25 episodes. A heartfelt thanks to our audience as well, both those who have joined with us today and those who are with us from the beginning. Your engagement, questions, and discussion are what makes this session so enriching and meaningful. Finally, a special thanks to our tech team, whose support has been instrumental in making this session and this series successful. Thank you, everyone. We look forward to seeing you all in our future session as we continue to explore and advance the field of endocrinology together. So thank you, everyone, and good night to everyone.
Thank you. Good night. Stay safe.
Thank you. Good night. Bye-bye, everybody.
Good night. Good night.